Next group of talks will be from the Adult Reconstruction Division. Our first speaker is someone who many alums may not have had the opportunity to meet yet. I want to briefly introduce our newest partner in the Division of Adult Reconstruction, Dr. Ian Duensing. Ian's a true superstar. He has been with us a year and a half. He comes from two very good programs, Utah and Duke, which have been well known in the adult recon world. So we've been delighted to have Ian for the past year and a half. He's gotten very, very busy. He was actually the busiest adult recon surgeon last month. He's gotten very busy doing cases, great surgeon. And he's also really, I think, started to elevate our research program in the Adult Reconstruction Division. And I asked him to give an overview of some of the clinical trials that he is leading in our division. So he's only been here a year and a half. He's already the PI on two funded clinical trials. So he's going to talk to you about those two trials. And then the rest of the division will be up to give some additional talks. So I'll turn it over to Ian.
All right, thank you. So this is meant to be a overview of the current clinical trial efforts within the Adult Reconstruction Division. So I've been fortunate enough to have a great support here and been blessed enough to be able to be the site PI for several pre-FDA trials focused on periprosthetic joint infections specifically, which is a particular interest of mine. So really we're involved in three, but the first two I'll combine because they are two phases of the same study. So it's the abbreviated protocol for two-stage exchange, which they've named APEX. That's enrollment of the first phase was completed at the end of last year. We're now in enrollment for APEX 2. That's sponsored by a company called Osteal Therapeutics. And then the other one that we'll talk about is Trellis clinical trial, which is sponsored by Trellis Bioscience. And this is a little bit of a unique approach. It looks at a human monoclonal antibody called TRL-1068, which focuses specifically on the biofilm scaffolding of orthopedic infections. So APEX 2 is as I mentioned, it's abbreviated protocol for a two-stage exchange. It is a shortened 7-day treatment course for chronic periprosthetic joint infections of the hip and knee, sponsored by Osteal Therapeutics. It was initiated by a surgeon, last name Dubobian in Saginaw, Michigan, who apparently has been doing this kind of work for decades. It's currently in phase 2 FDA clinical trial, and it's based on the concerning but consistent published literature of nearly a 40% rate of two-stage exchanges not going on to receive new prostheses. Additionally, of course, depending on the source you look at, nearly a 20% reinfection rate, an exceedingly high cost. So the estimated direct and indirect cost of a typical 55-year-old male with a chronic hip PGI is nearly $500,000. And so Dr. Dubobian, in partnership with Brian Springer and Ortho Carolina and Charlotte, has created this clinical trial where I'll go into the details in just a second, but funded by Osteal Therapeutics, is a privately held clinical stage pharmaceutical company. And they developed this drug device combination product that they've termed VTX7. So for the patient specifics, this is a phase 2 study. So the inclusion criteria are quite broad. The goal for APEX 2 is 76 patients, a minimum of 24 hips, 24 knees. Because the criteria are broad, it's essentially anybody less than 80 years of age who meets MSIS criteria for chronic hip or knee PJI with less than 2 attempts at a two-stage exchange. So even if you've had a prior two-stage, it doesn't exclude you from the study, which is one of the interesting parts about it. So again, as I mentioned, APEX 1 recruitment finished in fall of 2022. We're now in the second phase of this recruitment and only a couple months into that. So for patients who qualify and decide to enroll, they're randomly assigned to treatment with either VTX7 or a standard two-stage exchange. They remain randomized until they awake from the first surgery. And this is an overview of the study process. So regardless of the group patients are randomized to, they either they undergo the stage 1 resection where the infected prosthesis is removed, they undergo debridement, lavage, irrigation, and then you move on to the interstage portion of it. So if you're in the control arm, these patients receive a cement spacer per surgeon standard of care, 6 weeks of antibiotic, systemic antibiotics per protocol, and then a 2-week holiday, followed by reimplantation at appropriate interval. In the experimental arm, these patients have this spacer placed, a VTX7 spacer, and they receive local antibiotics only. So the antibiotics are instilled into the joint. They receive no parenteral antibiotics, and that goes on for 7 days. They remain in the hospital for 7 days. They're now weight bearing for 7 days, and then it's between 7 and 10 days, they're reimplanted. They then receive the typical postoperative antibiotics for 12 additional weeks after that. So this is what the spacers look like. It's a little bit different. So more in line with the static spacer, there's 3 components. These components are fenestrated, and they allow the installation of antibiotics not only into the joint itself, but also into the intramedullary canal. They're assembled inside too. You have a tibial stem, which is tapered and prepared by a hand reamer, femoral stem, which is prepared the same way. And then there's a adjustable and modular connector piece, 25, 30, or 35 millimeters to allow for appropriate soft tissue tensioning. That connector piece is attached to an irrigation line. This is sort of what it looks like on post-op x-rays. This is one of our patients who was treated successfully this way. And then this is the hip spacer, only 2 components to this. You have different head diameters, also fenestrated, and you have a femoral stem that's connected to the irrigation line also that has different lengths and diameters to allow good fit for the patient's anatomy. So once the study spacer is placed either in the hip or the knee, it's closed around deep sponges that are placed on the knee in the medial lateral gutter, or in the hip, it's deep to the joint capsule itself. That sponge is in continuity with a superficial vac. So you leave a 5 centimeter opening at the top of the wound that allows the vac sponge communication and the tubing to exit. So as I said, the tubing exits through the superior wound and is hooked to an antibiotic bag and a Veriflow wound vac. And then the sponges that are placed intracapsularly are connected via that 5 centimeter opening also to an external incisional vac. So it's all one big continuous system. The vac is then turned to a timed installation, lavage, and suction timed protocol through which the antibiotics are instilled. So it's a alternating cycle of tobramycin and vancomycin. So for tobramycin, it's 80 milligrams in 50 cc's of normal saline. That's the first medicine that gets instilled. It has a 2-hour dwell time followed by suction into the vac. And then that's followed shortly after by 3,000 milligrams of vancomycin and 1,200 milliliters of normal saline. And throughout the rest of the 24 hours, that goes in 50 milliliter aliquots with a 30-minute dwell time followed by suction into the vac. And that cycle is repeated for 7 days. Vanc and tobramycin levels are measured periodically, and then the dose of those medications that are instilled are adjusted as needed based on patients' daily labs, so serum, BUN, and creatinine, as well as vanc and tobra trough and peak levels. And then at a minimum of 7 days, but no more than 10 days, that spacer is removed. Back to the operating, spacer is removed, followed by reimplantation. And that's followed by 6 weeks of highly bioavailable parenteral antibiotics and 6 additional weeks of a PO antibiotic tail. So it's the surgical portion of it that's truncated or abbreviated. They receive the same amount of postoperative antibiotics. So there are 8 participating sites currently in Apex 2. They're attempting to recruit more. Expected recruitment per site is around 9 patients. We had a late start to Apex 1, and we were still able to recruit 6 patients, 3 control and 3 experimental. And so far in Apex 2, we already have 4 patients identified, 3 recruited, working on surgical timing with 1 completed so far. And we're just over a month in, and we're already one of the leading sites in Apex 2. So we're coming up on 1-year follow-up data. I don't have any outcomes data yet. There is a FDA safety process where all the data has been submitted and their recommendations at this point for Apex 2 were continue with no modifications required. So from a safety standpoint, they've done well. And so I'm going to shift gears and move on to the Trellis clinical trial. This is sponsored by Trellis Bioscience, which is a basic science company. It's a phase 1 double-blind study looking at TRL-1068, which is a human monoclonal antibody. It's a single ascending dose study, like many phase 1 studies, with looking at patients, again, with PGI of the hip or knee undergoing primary 2-stage exchange arthroplasty. So this is a first-in-human FDA clinical trial. There's some preclinical animal data to support the use of TRL-1068, which again is a human monoclonal antibody that targets the scaffolding of biofilm. So it is an IgG1 kappa antibody. Obviously, biofilms are the bane of orthopedic infections, and they allow for the physical production of bacterial elements. They induce a sessile phenotype that's relatively refractory to antibiotic treatment when you compare those to planktonic organisms. And so this antibody, the goal is to target two key extracellular proteins to break down the biofilm. They're in the DNA B2 family, and those are histone-like protein and integration host factor. And so disruption of this established biofilm on orthopedic implants theoretically increases the percentage of bacteria in the planktonic state and has the potential for increasing the success of two-stage exchange. And so these are some of the rodent models, the preclinical data. There's really 3 of them that are worth mentioning. And they're all murine models looking at either subcutaneous soft tissue cage infections and infective valve endocarditis models looking at both MRSA and Acinetobacter infections. And both of these showed significantly reduced adherent bacterial counts. These are some scanning electron microscopy images. You see the control group on the left and the TRL-1068 group on the right. And that's for both Staph aureus and Pseudomonas. And you can see after treatment with a human monoclonal antibody, the significant reduced biofilm formation on these implants and the increase in planktonic state, which is very interesting. So again, this is a phase 1 study. So the primary objective is safety at this point, also looking at side effects, best dose, timing of treatment, and tolerability of 1068. The inclusion criteria as a result of this are much more strict, particularly as it relates to comorbidities and infection diagnosis. So one of the issues that's been the biggest hurdle is screen failures because of culture negative infections. You have to have a positive culture and sensitivities for these patients to be able to be enrolled. So patients who do qualify and decide to enroll will be randomly assigned to either treatment with TRL-1068 or a saline placebo in a 3-to-1 randomization. And so the actual study protocol, 8 days prior to their stage 1 surgery, they undergo a single infusion of TRL-1068, and that's 8 days prior. 2 hours after the infusion of this medicine, they receive pathogen-directed antibiotics for the entire week leading up to stage 1. So again, like a lot of phase 1 trials, these are drug trials. These are incremental dosing. So they've completed dose level 1 with 4 subjects at 6 milligrams per kilogram. They've just recently completed dose level 2 at 15 milligrams per kilogram, and that was 12 subjects in that dose level. And they're starting enrollment in dose level 3, which would be 30, which is double that rate. And the goal enrollment for that is 12 subjects. This is kind of where we're entering. We've been a little bit late to the game in terms of site activation. So we don't have any enrolled patients yet, but we're beginning the process currently. So after the 8 days of treatment, these patients are taken to the operating room. They undergo the stage 1 resection in the typical fashion. So explanted devices and spacers then are taken from the patient, taken from the operating room and moved to an adjacent lab where they're sonicated in colony forming units per milliliter determined on those implants. They then receive standard of care pathogen-directed antibiotic coverage for 6 weeks or until the second stage surgery occurs. So again, there's a investigator meeting this weekend actually looking at some of the outcomes data. So unfortunately, I don't have anything to present on the outcomes just yet, but from things that we've heard, the safety has been very well tolerated in the first 2 dose levels, and the outcomes seem to be promising at this point. So I think I'd like to say a special word of thank you. I don't think a lot of sites can handle multiple FDA clinical trials, especially with overlap and competing recruitment. And I think even fewer can handle phase 1 first in human studies. And I think very few, I don't know if any have, but certainly it can't be many in UVA orthopedics. So I'd like to say a special thanks to Eric McVeigh and Milos and the entire clinical research team for really doing all of the legwork and making these 2 studies possible. So thank you.
Good afternoon. It was so nice to see old friends and new friends. My classmate, 2 of them, Case and Todd. We had a great time last night. Stayed midnight, so Bobby kicked us out, right? Had a good time. And so we're going to continue to enjoy the weekend. So, it's CUI alumni talk. So today I'm going to talk about osteonecrosis. This is, as all you know, you probably will deal with osteonecrosis. Doesn't matter what your subspecialty is, you're going to see such a patient. And you all know that I came to University of Virginia because Dr. Wang, and he has been a legend in the field of osteonecrosis. That's how I joined the group and later faculty, and I continued to do research in this area, involved with many projects. So I'm going to talk about the early stage osteonecrosis classification through this ARCO group. Basically, this is the special group society focusing on the osteonecrosis and bone circulation. ARCO, you probably know that that's the Association Research Circulation Osseous, established in France, 1960s. Go ahead.
Not working.
It's not working.
There you go.
Okay, so as all you know, classification system for osteonecrosis, probably everybody knows the fecal and RLA. However, you know, that has been a long time ago. MRI was not involved. UPenn or Sternberg classification is so complex, nobody can really use it. And that's why later on, ARCO group developed a new classification, but also very complex. It's harder to use. And all other classification systems not either outdated or not reliable or not validated. So that okay, all right, I got it. So 2013 in Chicago, ARCO group basically started to work on this problem. So at that time, we have a workshop and established the concept. Basically, we want to develop a new classification system that's reducible, meaningful, and also simple to use. Any clinician, any orthopedic surgeon can use it. Focus on size of the lesion, location of the lesion, and the amount of the collapse or crescent sign. As all you know, those are critical parameters for diagnosis of osteonecrosis. That's the group picture. You can see Dr. Sternberg standing in the front line. And later on, 2015, we again continued to, discuss on this topic in Taiwan. But until 2019, a lot of discussion, very hard debate, but couldn't come to agreement until this 2019 in China, Dalian. So we developed a task force, started to work on this. So Dr. Cui was also a former fellow with Dr. Wang, spent 1 year with us here at UVA. And, him and I, we got together talking about it. What's the best classification for early stage osteonecrosis? You all know that if it's stage 3 or stage 4, basically joint replacement, and then stage 1, stage 2, what are you going to do? How can we define a stage 1 and a stage 2? So here's the picture. If you can see, you pick up the center of the femoral head, a straight line to the dome. If the lesion fall into the medial half, that's type 1. This type generally don't progress. If you fall between, medial and lateral, but not beyond the acetabulum, so this is type 2. And if beyond the acetabulum, that's type 3. So it's very simple, very easy to use. Anybody can, learn this system and can use it. And so basically, we wanted to compare this system to previous system that quantify the lesion. And so that's basically, we have a modified Kerbal system, Japanese investigate committee classification, and also Sternberg classification. And, basically those are 4 systems. We're going to compare them and see which one is going to be the best to validate, to predict the future collapse. So as all you know, Kerbal angle, you have to measure at a mid-coronal and also mid-sagittal 2 images of the MRI. You need a galvanometer to measure that. You need to find that imaging. And then this Japanese group, you have to divide acetabulum to 4 parts, and then look at type A, type B, type C1 and C2. So again, it's very difficult, not easy to use at a clinic. But however, they have a best predictive value for quantitative this prognostic. So this is probably the best system. That's why we pick up this to modify, make it more simple but more reliable. And there's a Stanford system. You can see all the tools, how you measure it. Almost anybody hardly can do it, except specifically for a researcher spend a lot of time get images to measure it to quantity. So we had we basically this study was conducted at the University of Virginia. Dr. Wendy Norco here sitting in the audience helped to design this study. So we have a part 2. We have 40 sets of CT images. Why we use CT images? Because that's going to eliminate any basically like a stage 3, like crescent signs. We don't want to miss that part. That will be excluded. So because the CT is more sensitive for that. And then we have this, readers to look at read the system, use this 4 different system to assess all the images. But all the images was randomized. Every reader will use a different, order of the images. So finally, only the a couple of researchers here know which one is which, and they will document all the results finally. And also, we have a group of expert panels to look at all those images, agree on the final diagnosis. So the readers' results will be against those expert panels' final diagnosis. And also, after we finish, this is the first study, we used another group, 104 early stage osteonecrosis, to validate the first part of the method. So this is the best design. Thank you, Dr. Narco. This is great. I think everybody agree on that. So we have first part 1 study, we have 8 evaluators, including 4 ARCO board members, 2 osteonecrosis experts, and then 2 orthopedic residents here from UVA. And again, we have that 6 experienced surgeons served as expert panel. And so this study, part 2 study, we have another group evaluators not knowing this system at all, and then let them to do another setup to validate this first study. So if you look at the group 1, we have 40, group 2, we have 104, and look at their basically demographic data, basically same, no difference. And if you look at the first group, look at all those very complex comparison between those among those 4 groups, and the data showing basically this new classification system give you better, the predictive value. And that, again, use the 2 trained tests to demonstrate the normal classification showing a significant predictive validity of the future collapse. And this is another basically assessment using ROC analysis, basically that will show area under the curve, the normal system is the best. So that's predict either not a collapse or collapse. So again, all those studies basically showing, the new method is much easier, much accurate, much, prognostic. So and then we performed a second study, basically showing the same data. And use a Kaplan-Meier survival curve, you can see that basically if type 1 is a small lesion, it's no collapse. If it's a medium size, that means type 2, it's better than the large lesion, that's a type 3. So any lesion, even beyond the acetabulum, is going to collapse. So this basically, from this study, we show that this new method is reproducible and it's meaningful and also simple to use. So I just want to show this picture again, and you can see how simple it is. And I would like for you to remember this system and start to use this. The reason is that if you see a lesion on the medial, 50%, that's a small lesion. So generally probably don't do anything. It's not going to collapse. If you do core decompression, you don't do it, or you do it, probably result the same. If it's a type 2, generally core decompression will be able to be effective, to some extent. But if it's a type 3, beyond acetabulum, it's going to be more than 900% is going to collapse. Doesn't matter what you do. So probably prepare to do a total hip replacement. So this kind of like what I already mentioned, a Steinberg system is too complex. It's hard to use. That's why you have a huge variation between inter or intro observers. And similarly, like curval angles that classification, and also Japanese. So this basically is a new system. We do have some limitation. It's just based on CT imaging. It's more accurate, but it's rarely used at the clinic. We did have the plain X-ray there. They compare to CT imaging, not a big difference. So basically, even X-rays you can use just like what we did in study on CT scan. And again, some sample size is still small. Better to do a larger scale multi-center study using MRI in the future. So this is basically conclusion. So 2021 ARCO classification is highly reliable and valid. ARCO group recommend using this method as a unified classification for early stage osteonecrosis of the femoral head. So I want to mention a few our co-authors here from UVA. You can see Dr. Wendy Novikov here, James Burgess, Dennis Chen, and Nicole Quillen, participated in this study. And Jeremy Haynes was a Adult Recon fellow that year, I think 2021. And so after just recently published this article just before the 2022 Seoul in Korea ARCO meeting, the group actually celebrated, public with this publication new classification. They have a special way to do that in a beer bomb. So that's what we did there. And so I want to take our opportunity to thank my mentor, Dr. Wang. This is a lifelong mentorship, and also Dr. Jaffer for his support to research and my career here. So, to be successful here, this really, he created such a good environment. So nurture, every younger faculty to be successful. And any questions, I would, we'll find time to answer you, and also enjoy this beautiful new building. I got these pictures. Actually, I was there at the the event. Really love to work here, and not only enjoy this facility, and also my colleagues. So that's how every day you are so happy to come to work. Thank you.
Thanks, Trey. Obviously, that represents a tremendous amount of work over many years, and congratulations on that. Thanks to Ian for demonstrating some of the ongoing clinical trials work that is done in our division. We have a lot going on in adult recon. I had planned to talk about some of the clinical research we had done looking at robotics and total knee arthroplasty and the impact on resident education. We're running a little bit behind, so I'm going to modify my talk here a little bit. Can you pull up my slides there, please? This was some work that we had done in conjunction with the Miller Review course, looking at the impressions of our senior trainees as to the impact of robotic total knee arthroplasty on their education. As I say, I think we'll speed through this. The mouse. My disclosures are here, not relevant. First, what I want to do, though, is recognize Thom Brown. So, as many of you know, Thom is retiring. It's a significant event for us in adult reconstruction. Thom has, I know, been instrumental in the education of many of the people in this room. All you sports guys who go out think you're going to do cuffs and stuff all day long, end up doing total knees. I'm sure you do them the way Thom taught you to do them. And Thom's also been a tremendous mentor as well as a teacher. And Bobby, very eloquently spoke on that. It was a great lead-in to our division presentations here. In recognition of everything that Thom has done for this department and our division over many years, we've just recently established the Thom Brown Lectureship in Adult Reconstruction. This is an endeavor that we think is going to be very important for the department in terms of education. Thom, as you know, has been really dedicated to resident fellow education, and this will allow us to bring in a premier and prominent adult reconstruction speaker every year for the department. So just like Dave Deduck mentioned earlier, he's going to be hitting you up for money. I'm going to do the same thing. Bobby and I have provided some seed funding for this lectureship, but this is going to be, one of the many ways that we will honor Thom and his contributions over the coming year. So please, first of all, thank Thom for everything he's done for our department. And certainly won't be the same around here without Thom, that's for sure. So I do want to leave Thom some time to give his talk, and I'm really just the warm-up guy for Thom anyways. He's going to talk about robotics and his experience. I'm sure everybody in this room is aware of robotics and how they're really everywhere now. This is, unless you've been living under a rock for the last 10 years, you've seen billboards for robotic total knee arthroplasty. It's in the New York Times, not uncommonly. This is one of my favorite advertisements from India. It's gone worldwide, where apparently the robot allows them to do surgery without any bone loss, which is shocking. I'm not sure how they do that. Of course, you feel better faster with the robot. That's certainly a proven statement. 100% accurate. Robot's 100% accurate. So that's a totally that's a different game that I'm involved in. And of course, the market's growing tremendously. So we'll continue to see the increasing influence of robotics and total knee arthroplasty. I just want to play this video. One of the concerns we've had as educators is this idea that residents are coming through now. Many of them are only seeing robotic total knee arthroplasties, not at our program, of course, but at many programs around the country, residents are coming to our fellowship interview and saying, 100% of the knees I'm doing now in training are with a robot. And that really raises questions. What happens when the robot doesn't work, right? Do you understand the fundamentals of total knee arthroplasty? Are you going to rely on that machine, to do your cases? And what happens when that machine, isn't working? Do we have any sound at all for these videos? Will it? Let me see can you play this video? I don't know that I can. Can you play that? So this is the concern here, this idea that over-reliance on technology can be bad. Yeah, we're not going to get the sound, of course, but many of you may know this clip from The Office, where he says, no, the machine knows. The GPS says go this way. The machine knows. And you can see how that ended up, right? So are we going to get to the point where you're in the operating room, the robot tells you to do something, you do it, and this is what happens? So to try to get a sense of where we were in terms of that, we developed a survey. I'll just, again, run through all the data. I'll tell you the bottom line. The bottom line, what we found was that 2 out of 3 residents in 2022 are being exposed to robots in the operating room for total knee arthroplasty as part of their training. And 1 in 5 are seeing robots in over 50% of their cases. The majority of their training actually involves a robot. And certainly the robot may assist with education, but what we found in our survey results were that many of the trainees were concerned that it was in fact encroaching on their understanding of total knee arthroplasty, the principles and standard instrumentation. And many of them were skeptical as well. We asked them, are you going to use the robot? And many people actually used the robot in their training, said no, they didn't want to use the robot in their practice. So interesting results. I think this is a very open and hotly debated question right now in the arthroplasty world. And I'm looking forward to hearing what Thom has to say about his experiences. Thom, as you may be aware, started using the robot a few years ago here. Part of which I know was to improve education and training of our fellows, many of whom who had trained on standard instrumentation and wanted to learn how to use robotic technology in the operating room. It's rounded out our program very nicely, and Thom's going to come up and talk to you about his experience with that. So thanks very much. And all right. Thanks, JB. I'm going to talk a little bit about robotics in total knee, and it's unusual that the old dog is learning the new tricks, and the younger dogs have been a little bit less interested in adopting new technology. And I'm not going to sit here and debate him and say everything he said is wrong and everything I say is right, but
this is gonna be more provocative, I think, just to let you think about things and, you know, are we really doing that good of a job? So I have no conflicts to discuss. I'm not involved in designing the implants or robots, but I will tell you I'm a graduate of the School of Hard Knocks, and I've been through 7 different systems as a knee surgeon. Posterior stabilized, femur first, gap balancing, mobile bearing, trying to find the holy grail, and never really found it. And I think it's part of it because we always compare knees to hips, and it's always a poor comparison because the phrase that comes up to the hip patients want to hug me and the knee patients want to slug me, because you never know if they're going to be happy. It's always you're getting ready to go in that room and you don't know. And that was part of the reason we're trying to find something. Can we do a better job? Before I go any further, there's a lot of people in this room to thank. I want to thank Dr. Wong. He gave me the opportunity to be up here 20 some years ago. Gave me the opportunity to be in this situation. And then to Dr. Abel and Dr. Chaba for resurrecting my career during some tough times. And this building is an amazing testament to Bobby's leadership and vision. And I know he's given you a whirlwind tour of this facility and all that it has. But there's more to this facility than you know. Bobby has really thought of everything. And there's a special room that we haven't seen yet where Bobby plans his next conquest. And I'm hoping to come back on a part-time basis and serve as a guard for him in this room as he plans his next move. As he said when he first started as a faculty here, world dominance was on his dry erase board. All right, moving on to total knee. So why change? So the outcomes are not as good as advertised. You know, it's the most pervasive operation in our society. Everyone in this room outside of your professional career has a family member or a close friend that's either had a knee or is contemplating having a knee because of knee arthritis. And also looking at, from my standpoint as a teacher, the educational experience of residents and fellows. I'm not going to go in too much about all the different types of robotics, but they're not all the same. And they're expensive, and they definitely will foster technological dependence, which may not be a great thing. So again, it's a good operation, but not a great operation. 1 out of 5 patients don't love it. Okay, it's painful, stiff, swelling, feels mechanical. You know, it's too big. You put a too big a knee in me, or whatever it is. So not everyone is thrilled with their operation. Again, why is that? This operation is growing. There's huge numbers in terms of prime, and we're a little bit behind, so I'm not going to spend too much time on this here. But just the revision burden, just because the number of primaries going in, several million knees will be going in the next 20 years, with over 350,000 knee revisions as a result of that. And the problem's not going away. The operation's not going away. Can we do a better job? Again, the reasons are unfortunately, they're not, when I was here with working under Dr. Wong as a fellow, we were seeing a lot of late failures, polyethylene wear, loosening, knees that have been in for a decade. Now we're seeing people that fail in 2 months, 3 years, instability, infection, component failure, things that, and a lot of this is iatrogenic. It's because it's not being done well enough. Early failure, I won't belabor this too much, but again, looking at the early, less than 5 years, infection, instability, ingrowth failure, wear, lysis, and loosening. Up in Pennsylvania, same thing. More than 50% of the knee revisions were done in less than 2 years after the primary operation. That's terrible, terrible outcomes. Revisions, even more sobering, looking at that 1 in 8 knee revisions fail within 3.5 years, and more than half of them are being infected or loose or unstable. So again, we got to do a better job the first time around, because the second operation is really not a whole lot better than the first in terms of the complications and survivorship. And then the educational impact. So I have made this comment over the years that total knee is like the burpee of orthopedic training, right? You use saws, hammers, drills, soft tissue handling. And even if you're never going to do a total knee during your practice, it's invaluable to have that experience as a resident or as a fellow. And robotics doesn't eliminate all of those steps of the burpee. It just changes them a little bit. You're just using a different kind of saw and jig. You're still doing all the other steps. So it's not quite, the dependence thing, I think, is a little bit overstated. Educational impact, again, looking at, gap balancing. How is it achieved? Using intramedullary, extramedullary, spacer blocks, tensioner, computer assistance, soft tissue releases. And again, the two worst phrases in orthopedics: looks good and feels good, right? That's how we gauge whether or not we like the knee. Okay, and the same thing happens in fracture care. Oh, it looks good. It looks good, but may not be a very happy patient. Robotics changes the paradigm a little bit in that you're able to make some virtual adjustments of the implant on the bone before you ever actually cut the bone. So the exposure is the same for the most part. The releases are the same. It's just the bone cuts are a little bit more safer because they're now controlled. So that allows for earlier integration of residents in training, especially for, as Bobby had mentioned, about the different ways of learning. Everyone in here is far more computer savvy than I am. So learning how to use the computer to do total knee is in some ways easier than it is to learn how to do it manually for a lot of the millennials in the room. Secondly, it provides earlier involvement, right? So it's a younger resident, and this gets back to another one of my, I brought this up years, that everyone in this room is, not everyone is at the top of the bell curve, all right? 50% of us are below average by statistical definition. Not everyone is a great knee surgeon. If you have to do knees, can you do them well? Can you, will this change that? Will the impact of robotics make the bullseye a bit bigger so that knees will have a chance of being successful and long lasting? So again, getting this, I'm not going to go too much into the specifics of it, but with this particular type of system, that it's impossible to go outside the cortical confines of the bone. So you can get a resident involved in doing parts of the operation. Either it's in the balancing of the initial part of it, the registration of the knee during the early part, or actually doing the cuts without any concern of cutting a ligament or a nerve, with very minimal retraction during the surgery. So again, it allows for people to get involved sooner than they would otherwise, especially if you have people that are early in training. This happens all the time. Our program, unfortunately, has 2 and a 5, and that's been going on for 30 or 40 years. A 2 straight out of internship, hard for them to get involved in a meaningful way unless they are exceptionally talented with their psychomotor skills early on. So here's some of the things to think about. So if you want to start a fire, you're going to use does using a bow drill make you a better cook than using the Weber grill on the other side? So again, it's a tool. It's not a way of doing the operation. It's something else to help you along the way. Now, this may be somewhat contrary to JB's video, but again, do you want to use a sextant to get from point A to point B, or are you going to use GPS? Everyone in this room uses a GPS to get from one place to another when they don't know where they're going. I'm not saying that should be the only way you know how to do it, but it is valuable. And why is it valuable? And what's the rationale behind the need for automation and more assistance with technology? Let's look at aviation. So aviation, simulation training, pre-flight checklists, automation, autopilot, computer-assisted navigation, human backup with rare breakdown. And that's what we're doing now in orthopedics and training, the exact same thing. Cadaver training, simulation training, timeout, making sure we're doing the right thing, computer-assisted surgeon, and then human backup with failure of above. Looking at total knee and total hip, this is going to be the new logo for orthopedic surgery, is running on the hamster wheel, because of it's becoming a volume operation. Unfortunately, we've done a terrible job as a profession of valuing what we do. So now the answer is, let's do more in the same amount of time. So volume is the only answer to compensate for declining reimbursement. And it is hard work. Every one of us that does this, that we're trying to do 2 rooms in an academic environment, doing 6 or 8 cases in a day, is physically and mentally exhausting. And it's a race to the bottom, unfortunately. So how many assembly lines are manned by humans only? None of them. Absolutely none of them. Yet we're trying to do this all ourselves, trying to prove that we can master all things and we can do more in the allotted time. Difficult to do. So admission is expensive. Is it affordable for everyone? I'm not sure. Is it too much of a good thing? And that's really what JB's study was saying, that, you know, if the pendulum swings too far to the other side, you have difficulty in knowing how the principles of doing the surgery. It does increase the surgical time versus a conventional knee. However, when you look at resident involvement in robotic surgery, the time, there is no time increase. So it's not as painful from that standpoint. The published outcomes haven't shown it to be better, probably equivalent. And I can't answer that question whether or not the technological potential dependence is a good or a bad thing. Things to consider. So I think, you know, from our standpoint, we've tried to provide an eclectic experience here: manual, computer assisted, different surgical approaches, et cetera. And too much of any one thing compromises your involvement or education and training in the other. So at the present time, it's hard to say that one should supplant the other, but the balance should be struck. Healthcare costs are already out of control, and can we afford to continue embracing technology? But it's coming. You know, can we afford not to adopt it? Spine surgery is heavily involved now in robotic surgery for placing instrumentation in the spine, and we may get to the point where surgeries may be canceled because the robot is broken. I think that really will happen in the future. So I think it's here to stay. I think it's important to realize it's a tool. It's not a crutch. It levels the playing field a little bit in terms of perhaps making the operation a little bit more predictable. It allows for earlier, safer training involvement, and is easier on the body. And this was a study looking at surgeon work effort, and was actually lower doing the robotic surgery than it was doing manual in terms of the physical effort required to do the surgery. And it lends itself to some improved consistency with fewer outliers, regardless of your experience, skill, motivation. And again, I think it's here to stay. Whether or not it will supplant all the techniques, time will tell. Can we do better? Yeah, just looking at this, again, we always talk about how good a job we do. And you look at comparing, preventable deaths, and we have M&M conference every Wednesday, right? Or every, the first Wednesday of every month, looking at comparing healthcare to aviation, and that, what we do in healthcare in general equates to 3 fatal crashes a day. So we're not doing as good a job as we might think in terms of providing consistent care. And I think robotics are going to be part of training and become more pervasive in orthopedics. And I think I'll stop there. Thanks for your attention.
Thank you very much, Thom. Thom has been the definition of a true soldier. I asked him years ago to do direct anterior hips, and he said no. And I said, please, and he said no. And finally, I had to get on my knees, but he ended up doing it because we needed to, and he understood. He's been our fellowship director for joint replacement for, 15 plus years. And understanding the need to learn new techniques to improve our education, he's all about that. So he's become one of the busiest direct anterior hip approach surgeons in the state. And then I went back to him a few years ago and said, I need you to learn Mako. And he said no, and didn't want to do it again, but he ended up doing it. And he developed a big practice. And now we have Ian Joint, who also does it. And then Tracy Borsinger, who's doing her fellowship at HSS, is joining us this summer and will also be skilled in that. But I don't think you can ever replace Thom Brown's shoes and what he's done for this program. And I know all of you will agree with me. So he's irreplaceable, and it'll be hard to be here without him in this department. I've offered him Professor Emeritus, all this other stuff, stay involved. But as you saw, he's just going to go ride around the country on his bike. So we may never see him again.